Welcome to the Aaron Harber Show. This is part one of our special two-part series with Bruce Gellin. Bruce, thanks so much for joining me.
Aaron, thanks for having me.
You've got an extraordinary resume. You were the former Deputy Assistant Secretary for the U.S. Department of Health and Human Services, former Director of the National Vaccine Program. You're at the Sabin Vaccine Institute, President of Global Immunization. So I want to talk about global immunization and how have your experiences, your work in the field and in so many leadership positions, how has that shaped your approach to those challenges today?
So when I got to the Department of Health and Human Services in 2002, it was a time when they didn't have a focus on vaccines, at least within the Secretary's office, and they were setting that up, and that was the job that I took. 2002 was after 2001, and 9/11 was an important time, and there was increasing discussion about vaccines for health security, bioterrorism and the like. In that time period, there was outbreaks of SARS and then MERS and then bird flu, so there was an increased focus. So I think that was sort of the basis of my looking into and being involved, not just domestically but globally, because these are diseases that may occur anywhere in the world but could then occur anywhere else in the world.
So what have we done since then? Let's talk about bioterrorism. You don't hear much about that today. Why is that? And where are we in terms of countering those kinds of threats?
Well, I think part of the history was after 9/11. There was a lot of focus on the bad guys and the range of things that bad guys could do, and bioterrorism was among those. I think as we grew, as we began to look more at some of the naturally occurring infections, realized there was a lot of lessons that we could apply that would apply to either end of that. Part of that was also the recognition that a large part of what was going to be needed were the vaccines, drugs, and diagnostics to either prevent, diagnose, or treat any of these. And with that during the time that I was in government, there was essentially a new agency was developed to focus on that, to focus on developing these products that don't really have commercial value, but have huge national security value.
So what kind of progress do you think we've made?
There's an agency within the government that has actually developed a range of these products and worked them all the way through the manufacturing cycle and has them approved from the FDA, and a number of them are in our national security stockpile. So I'll leave it to you to figure out the numbers if you want to portray that, but there's been a lot of progress for not just bioterrorism, but for other things like radionuclear events as well.
So I'd be really interested in your take. I know you're not necessarily expert in every arena, but my guess is you have some thoughts or opinions about the progress we're making in terms of vaccines versus treatment. Obviously, two different concepts, one preventing the spread of disease and the other curing that disease. But let's start off with HIV/AIDS and what's happening globally in particular.
I think an important lesson from HIV/AIDS is the investment that we've made, we, the scientific community, in understanding the virus, understanding virology, and importantly, understanding the immune system and its reactions to these viruses that has given us a whole new grounding and opportunities. Within HIV/AIDS, again, I don't know all the numbers, but there's been a huge investment from the basic science in the treatments, and so now living with AIDS is living a full lifespan. Whereas when I was in medical school, when AIDS was just being identified, AIDS was a death sentence. So it's quite different. There's been a lot of struggles with the vaccine. There's a continuing amount of work on it, but I think that we're learning more and more lessons about the virus, the immune system, and how to treat it.
I'd be really interested in your take on Ebola, because obviously the 2019 Ebola outbreak caused a lot of concern. I'm also intrigued by how difficult it is for medical teams and health workers in certain parts of the world, the difficulty they have convincing people who are affected or could be affected that they should be vaccinated or they should be treated. Talk a little bit about that and those kind of challenges.
Well, I think that's a great question. Ebola teaches us a whole range of things, from the ability of viruses that we didn't know about to emerge and cause problems in humans and then cause outbreaks, to the way communities respond to these, to our ability to actually develop drugs and diagnostics for each of those. I'll start with the beginning. I mean, Ebola was discovered quite a long time ago, and there was a lot of understanding about how you could contain and control Ebola because they were in rural areas and small outbreaks. It's clear that that's no longer the case, and there's a recognition that these diseases can continue to spread. Your comment, though, shows how complicated this is, because just because you might have a product, just because you have a vaccine, doesn't mean you're going to be able to put out this fire, because you need to actually be involved at a community level. So what is particularly frustrating to the World Health Organization is the difficulty they have is working on the ground because of the security issues on the ground. Related to that are the importance of understanding the communities and understanding the cultural context in which these diseases emerge. I think one of the issues with Ebola specifically was the understanding that one of the ways that this virus would spread was person-to-person spread, in part when there was the care in the burial practices. That was so much a part of the culture that when others came in and said, no, you can't do that, there was a lot of frustration there, a lot of resistance to that, because it was such an important part of that culture. So I think what that teaches us, and it gets into the larger lesson about vaccines and other medical procedures, is how much we have to understand what people perceive about these and how they are going to value what it is you're telling them is good for them. I think without that, we're going to have this trouble all along. And I think one of the lessons we learned from Ebola, one of the lessons we're learning now in measles, is that unless we have an understanding of how people make decisions and what their understanding of the value of the vaccine is versus the threat of the disease, we're going to continue to have these issues.
All right, I want to jump to measles in a moment, but on Ebola, I think a lot of people in the United States aren't aware that vaccines have been developed quite successfully to address Ebola. Of course, the challenge with a vaccine is that they don't have indefinite shelf life, so it's not like you can have 1 million doses just hanging around all the time. Tell me about the challenge, really the logistical challenge of providing vaccines when they're necessary, as opposed to simply having them on the shelf and then running out of viability.
Well, so we can start at the end user point and work our way back. Let me start at the beginning, because I think one of the issues is how long it takes to develop a vaccine. That these are not instant, and part of the reason that they're not instant is that in the process of developing, you want to make sure that you have as full of understanding of how it works as possible, as full an understanding of its safety profile as well, before you deploy it more broadly. So there's a huge amount of work on the upstream end to better understand what it is that you're developing. You need to use first, you'll test these first in animals before you test them in humans. You'll start with a small number of people. And as a result of that, it takes quite a while to develop a vaccine. So increasingly, there's a look to try to think of how we can start to develop vaccines now at the front end to be able to shave some of that time. Not that we have to develop it all the way through, but so that when we need it, we've already saved a lot of that time because we've invested in some of that upstream work. Once you have a product, then the question is how you're going to use it. And there's the part about its distribution, and it's a part about it, the ultimate receiver, the last mile, the person who gets it. You talked about they don't have an infinite shelf life, and that's the case. And as you develop new products, you have to learn what that shelf life might be, so you're continuing to test it. At the same time, you have to make sure that it's going to continue to work. And so we have, as the U.S. government, as I mentioned before, we've stockpiled a number of products, and we have to keep testing them to make sure that as they're in the stockpile, they continue to be stable. It's not like that oil stockpile, which is somewhere in the southeast, I think. Oil is going to stay stable. If you need it, you can tap into it. These are products like any medical product that has an expiration date on it, but you want to make sure that as you're hanging on to it, you want to make sure that if you're going to put it in a stockpile, that stockpile is ready to go, and you have to test it all along. Then there is the next part about, if you have a vaccine, how you're going to distribute it. We learned many lessons, and we learn this every time. We learned this with the pandemic influenza globally just a decade ago now, about the importance that countries need to have plans of how they're going to distribute vaccine. Just because you bring it to them, you airlift it to them and put it on their dock, doesn't mean that they have a good plan to where it's going to go. And you can just realize that, and it's pretty clear that if you were going to go that far to develop a vaccine and bring it to a place, you don't want it sitting somewhere and not getting to where it needs to go. So a country, any country, needs to have an idea of who it is that they think needs to get it, what's the basis for that, and what's their plan on getting it from that warehouse in country out to the people. Once they get it, have to make sure that you're going to make sure that it's going to continue to be tested, but most importantly that the people value it and will line up for it when it's available.
And that seems to be key in certain communities where you can have the success of developing an effective vaccine, you have the ability to produce it in mass quantities, you have the capacity to get it to a specific country, community, you have healthcare providers who are able to administer the vaccine, but then suddenly you have members of the community who don't trust the entire process, and then you're stuck. What do you do in those situations?
Well, first of all, you've lined it out exactly right. Every step matters, and a failure at any one of those steps means that the rest aren't going to happen. So then we get to the last mile. And the last mile is a combination of logistics and behavior, in the sense that the logistics are making sure that it gets to where it needs to go at a time when people can access it. But at the same time, there needs to be an understanding by the people who are going to receive it of why it's been provided for them. Again, it gets back into the understanding of the cultural context. I think that the one advantage is that because immunizations have been a global phenomenon, mostly childhood immunizations, but everybody in the world, almost everybody in the world, is familiar with immunizations as part of a process. They certainly have their own impressions of what that is, but it's as a process, immunization is pretty much known by everybody. It's different when you take it to other than children, because most of the immunizations given around the world are given to children. But I think that that's where at least we have that grounding. It gets back to try to understand from the person's perspective, what are they seeing? What are they hearing? And what informs their decisions? So I think unless we can understand that, whether it's going to be in Congo or in Chicago, we're going to have that same issue.
All right, fair enough. We're going to talk more about vaccines and measles when we come back.
For information on how to help promote civil and mutually respectful discourse and support expansion of the distribution of our programs, please email info@harbertv.com.
I'm Aaron Harber, host of The Aaron Harber Show. I very much would like to hear from you about the program, so please send me an email with your thoughts. You can suggest what topics I should cover, what guests I should invite to be on the show, or even what specific questions you would like me to ask. This is your program, so send your suggestions to aaron@harbertv.com. I promise to personally read every one, so email me today. And most of all, thanks for watching.
The Aaron Harber Show may be viewed 24/7 at no charge from any location in the world at harbertv.com.
Welcome back to the show. We are with Dr. Bruce Gellin, and we're talking about vaccines. And I mentioned measles. You mentioned measles, so I wanted to talk more about that. In the United States, we thought we had eliminated measles several decades ago. What happened? And of course, in 2019, we surpassed over 1,000 cases of measles.
You know, in many ways, except for recently, measles is one of these incredible stories that nobody's paid attention to. When you and I were kids, everybody had measles. Everybody. They didn't really count it in the same way they do now, whether it's 1,000 cases or more than that, but everybody had measles. It is the most infectious virus known to virologists, period. And as a result of that, if you're susceptible, meaning that you either haven't been vaccinated or haven't had measles in the past, and somebody walks in this room who has measles, that 90% of the people in this room who are susceptible will get measles.
Airborne.
And that it lingers in the air for a couple of hours. When I was in medical school in New York and my infectious disease training, it was in the late 80s, and there was a huge outbreak of measles in the late 80s in the United States. 50,000 plus cases, lots of deaths. Measles is a serious disease. It's not just an inconvenient rash. And when I was there, I remember there was a time when the hospital, the head of the infection control part of the hospital called me and said, "We think somebody walked through the emergency room with measles." You can imagine the implication that has for our hospital. It's linked with Sloan Kettering and all the people who are immunosuppressed. So I got sent by ambulance out to the South Bronx to figure out if this person had measles, because it was going to set off a huge alarm because it's so infectious. It turns out that wasn't the case. Everybody was off the hook. But it was just a reminder of how infectious measles is. So that's why what we're seeing now with measles is really an indicator of where we are in the community. And it's not just the United States. There are pockets around the world, and pockets are important.
So talk about why we have this resurgence and why it's so significant from a health perspective.
Right. Well, from a health perspective, it's significant because while measles is a rash illness and inconvenient, because it's so, from a health perspective, measles is important from a number of perspectives. It's important from a health perspective. It's also important from a social disruption perspective. Let me start with the latter. Because it's so infectious, I think it was in the late 70s, when there were recurrent outbreaks in school systems, the schools couldn't operate because they'd have to just keep closing down until it would dampen and they could have kids come back to school. And that was the origin of the school requirement that unless you were vaccinated for measles, you couldn't come to school unless you had a medical reason not to do that. And so that was the beginning of that because the schools couldn't operate. It's a very disruptive disease. It would be for schools or for any system if periodically or frequently the system had to close down to make sure that this fire dampened because these sparks took off. From a medical perspective, it is an airborne disease, but it's also spread. It's a respiratory disease. And I think what's important to recognize is that while you see the rash, you have that rash on the inside as well. So that's where people run into trouble with pneumonia and other complications of measles because you have that same rash on the inside, and now you can envision how that gets you into trouble medically.
So how does the non-vaccination kind of movement or contingent impact this? And what do we do to address that challenge?
Because measles is so infectious, it'll find anybody who's susceptible in the community, to the degree that unless there are almost 95% of the people in a community are immune because they've had measles or had disease, that virus will find those other 5%. And when it does that, it may be in ones or twos, but if that 5% is larger because they haven't had their vaccine, then that's where you see these outbreaks.
Give me your thoughts about the concept of community and community interests and the idea that there are people today who don't have confidence in certain vaccines and in some cases any vaccine or who are totally anti-vaccination and are not getting their kids vaccinated, may not be vaccinated themselves. What kind of threat does that pose to others, number one? What kind of threat does it pose to themselves? And what kind of ethical obligation do you think someone has who may have, for example, not just a philosophical objection to vaccinations, but perhaps a religious objection?
So when I look at communities broadly, I'll sort of group them into three types of people when it comes to vaccination. They're the people who understand it and have heard the recommendations and they go to their doctors to get them and their children vaccinated. There are people who, for a variety of reasons, don't like anything about vaccines and will tell lots of people about it. And then there are people in the middle who are just trying to do the right thing and they can't figure out what it is. So I think that's the part we need to focus on, those other two parts mostly. We need to reinforce the people who are getting their vaccines, how important it is, so that they continue to do that, because I think that we underappreciate how important it is to reinforce that. But also we need to recognize that there are a lot of people who are just trying to sort it out. They're trying to do what they think is the right thing for their child. They've read this, they've heard that, and they can't figure it out. I think for those people, we need to try to, for each, and it's not for every vaccine, but each has its own story, and people have their own issues with any of these. And so to really try to understand, what is the problem here? What is the issue here? And so increasingly, we're teaching the pediatricians and family physicians to better understand what is the issue, what is it that they're worried about, and the degree to which there can be a conversation about that. I think part of this is there are lots of facts out there. We need to make sure that people understand what the scientific community has seen and the basis of vaccine development and the basis of recommendations, but also try to figure out when somebody comes in and has an issue, take some time to try to understand what that is and see if you can work your way through that.
So one of my concerns is that I see a lot of information about the medical or scientific basis for vaccines. I don't see a lot of discussion about the concept of community immunity, that we have an ethical obligation to the rest of the community to be vaccinated.
Well, that has been a debate since vaccines have been around, the individual versus the community issue. I guess an analogy that I think helps when you take a step back from vaccines is a four-way stop sign. If you approach that intersection and it says four-way stop, and you think everybody else is going to stop, you don't really have to. But if two people approaching that intersection at the same time have that same mindset, you can imagine what's going to go on at those intersections. So I think there's a lot of that. And so there are those who say, well, I think I don't have to do this because everybody else is doing it. And therefore, I'm now protecting myself from this problem without having to take any risk, and the risks are not zero, but they're quite low. And that's where we need to have this discussion about the impact on the community.
All right, we're going to take our last break. We'll be right back with Dr. Bruce Gellin.
For information on how to help promote civil and mutually respectful discourse and support expansion of the distribution of our programs, please email info@harbertv.com.
Safely stop fires around your home. Introducing the Fire Ice XT 20-ounce aerosol canister. Fire Ice XT is an eco-friendly water-based fire suppressant gel. Unlike a traditional fire extinguisher, Fire Ice XT is a highly effective, non-toxic firefighting agent that is easy and safe to use around your home, family, and pets. Available at Amazon.com or call 800-924-4874.
I'm Aaron Harber, host of The Aaron Harber Show. Find us on Facebook to get all the latest updates, see behind-the-scene photos, and make comments and ask me questions. You can see episodes before their TV broadcast, so like the show today. I'm Aaron Harber, host of The Aaron Harber Show. I very much would like to hear from you about the program, so please send me an email with your thoughts. You can suggest what topics I should cover, what guests I should invite to be on the show, or even what specific questions you would like me to ask. This is your program, so send your suggestions to aaron@harbertv.com. I promise to personally read every one, so email me today. And most of all, thanks for watching.
The Aaron Harber Show may be viewed 24/7 at no charge from any location in the world at harbertv.com.
Welcome back to the show. This is our final segment in part one of our special two-part series with Dr. Bruce Gellin. So one of the questions I had just out of curiosity is if everyone in the United States were properly and fully vaccinated per medical and scientific recommendations, what impact, has anyone studied to see what impact that would have on Americans' health, on the economy, et cetera? Do you have any sense of that?
You're probably somebody has. I don't know it. But I think what the important piece of that is it tells you how much vaccines have changed health and have changed society. When you and I were kids, what were called the usual childhood infections are now called vaccine preventable diseases. And when I was at the CDC learning about vaccines, every year we'd have a lecture about the eradication of smallpox, and it had been X number of years since smallpox was eradicated. And we used to laugh about that in the sense that we're now watching in real time a number of other diseases essentially disappearing because of the development and widespread use of vaccines.
Such as?
Such as for childhood meningitis, there are two vaccines that have been developed and are widespread use. Haemophilus influenza type B, called Hib, Haemophilus influenza type B, and a vaccine for the pneumococcal infections, so strep pneumonia. And those two diseases have essentially changed childhood and have changed medical training for pediatricians who used to take care of these children with meningitis every day, and now it's grand rounds. So in the sense that it has really changed the face of childhood in America, and as these vaccines are now being deployed globally, we're seeing it globally as well.
So I want to jump back, though, quickly to, because these are decisions, the ones you mentioned are decisions parents make as well. Have Americans changed their perspective and belief and really confidence in science since you've been involved in these challenges?
You know, I can't say that, only because I haven't studied that. But there was a report this week that looked at trust in science and trust in scientists and their confidence in those parts of the system, trust in institutions more generally. I think what we're hearing is there's been some decline in that. And I think we need to better understand that because I think we're at risk unless we better understand why it is that there is not this trust in institutions. At the same time, we know that facts are not the whole answer, that there are important stories to tell that will inform people's decisions as well.
But it seems to me that we've evolved, though not necessarily in a positive way, where there was an assumption 30, 40, 50 years ago that facts were facts. And now it seems that a lot of groups have their own set of facts. And certainly we see that in the political realm. Is that affecting how people look at science?
So I think that, as you said, this is going on in lots of different fields. And we've seen this in immunizations for quite some time. And what we've recognized is that we need to help people find the facts. We need to understand why it is that they believe some of the facts that are different than what science has developed, and then to try to figure out how we can then help them put that facts into a story. It's clear that this is not just the deficiency of facts. So people need to better understand about what the value of vaccines are and why they're important. So to me, it gets back to the importance of the frontline clinician, that there's probably no more important factor in a decision than the discussion by a doctor with their patient or the parent. And maybe that's where the healthcare system is a bit of an issue, that if you are part of a group practice, you don't have the same trusted physician you had a long time where you've developed this relationship where you know that this is the person you have your trust in. I can't speak about that for everyone, but I think we need to understand about how physicians are helping patients wade through the information that they're seeing to help them make the best decision for themselves and their children.
So 2 suggestions. One, it seems to me that pediatricians need to be much more proactive in terms of educating their patients, and that maybe many of those medical professionals assume everybody knows what they know or believes as they do in the accuracy of facts. And number 2, why isn't there more of a public service advertising campaign that talks about that? I mean, you have news stories about measles, for example, but I don't see any public service advertising effort specifically addressing these kinds of issues. I know we're out of time, but give me a quick response.
It's a great question. I think that there needs to clearly be, we need to communicate better. But each one has its own story. So if there's a parent who has an issue about measles, it's not going to answer an issue that they have about HPV or something else. At the same time, people have different information needs. So a national campaign probably is unlikely to get to the right people very regularly. We need to better understand how to tailor our messages to address the issues that people have.
But then again, if someone does not believe in the efficacy of vaccines, or they believe vaccines cause autism or certain problems, which while scientifically has been proven not to be the case, then that's a more widespread issue. That's not someone saying, oh, I'll go with a measles vaccine, but I'm not going to go with a tetanus vaccine or whatever. That's somebody who is, in many cases, these people are simply anti-vaccine.
There are clearly those who are anti-vaccine, but there are those who don't understand and are worried about the specific things they've heard about a vaccine. And so while there's a temptation to lump them all together, I think we need to understand on any individual case is what's the issue and how can we help to work through that.
All right. Well, this is the end of part 1 with Dr. Bruce Gellin. Make sure you watch part 2. I'm Aaron Harber. Thanks for watching.
Please contact us. We want to hear from you. And thanks for watching.